Good afternoon, everyone, and thank you for coming. Happy Father's Day in advance of the fathers that are in the crowd. Hope you get lots of presents. Periodically, we like to highlight resources that we have here at Hoag that many of our own staff don't know exist. Do you know that we have a nationally accredited stroke care program here at Hoag? You knew they're pretty good, but national recognition is also nice to hear as well. And the director behind all of that, and of course it's a team effort, is Dr. David Brown, who is going to give us up to date on acute stroke therapy. He trained at New York Medical College in Mount Sinai and did a fellowship in stroke and cerebrovascular disease at Mount Sinai, also in New York, and then went west, and here you are with us. He's received Teacher of the Year Award of the Mount Sinai Department of Neurology, National Stroke Association Research Fellowship Award in Cerebrovascular Disease, the American Heart and Stroke Association Achievement in Neurovascular Science and Medicine at 2012, and designated the Hoag official for American Heart Association Get With the Guidelines Stroke Program. He's given multiple lectures on stroke care, both to professionals as well as to the public. He's a recipient of research grants on stroke care that's going on actively here in our neurosciences division at Hoag. And he's written numerous articles and abstracts related to stroke. In the evaluation form in front of you are your listed the desired outcomes that he will try to address for us today. He has no financial interest that will impact this particular topic. So please turn off or mute your cell phones and help me welcome Dr. Brown.
Welcome all. Thanks for coming. Today I'd like to talk to you about acute stroke care and how that's been transformed in Orange County over about the last 10 years. So stroke has undergone a fundamental change over the last 10 years. 10 years ago, we were still hampered by a nihilistic model of where patients weren't expected to do well. It was driven by usually a single physician. These days, we're trying to be more collaborative, meaning collaborative between physicians of different specialties, as well as nurses and other specialists. So we're using a multidisciplinary approach, and we try to develop the program based on the best data that we have available, and we have quite a bit of data. So the old view of stroke was one of disability following stroke and potentially decline. Our view of stroke at this point is we're trying to interrupt stroke in process, resulting in better recovery and patients getting back to their prior level of functioning. So just the epidemiologic slide that everybody has to have. Well, how important is this problem? Well, there are about 800,000 strokes in the United States every year, resulting in about 4 million Americans living with disability due to stroke. Stroke is now the 4th leading cause of death in the United States. 10 years ago, it was the 3rd leading cause of death in the United States. It still remains the 2nd leading cause of death worldwide, however. It significantly has a significantly higher mortality rate than a stab wound, and it's also an important disease for women. Many more women die from stroke than from breast cancer. However, it remains the leading cause of long-term disability worldwide. However, despite all we know from the last 20 years, still only about 5% of ischemic stroke patients are receiving thrombolytics or intra-arterial therapy if you look at the country as a whole. And still only state-of-the-art centers are averaging around 15% treatment rates. So we certainly have a long ways to go. This is the original study published from the National Institute in Neurologic Disease and Stroke study for TPA. And we can see this data is just about 20 years old at this point. So, they were collecting data 20 years ago on the patients that they eventually published. So this was what started the revolution in stroke care to a more active form of treatment. But it happened a long time ago, and the adoption of this type of treatment has been taking longer than many of us would have liked. So just to review, what is TPA, tissue plasminogen activator? It activates fibrin-bound plasminogen in a blood clot. You can see the cartoon here, which causes the plasmin fibers to be broken up, and that's how it works. This is a slide. It's about a 20-year-old slide from the original slide deck from one of my colleagues who was involved in the original study. And the slide looks a little old-fashioned. I like to keep it for that reason, to kind of remind people how old the data is. But what it says is pretty fundamental to all the care that we give even today. And basically the point of this is you can see that the odds of a favorable outcome are significantly better if patients are treated very quickly within an hour, as opposed to 3 hours, where the odds of a favorable outcome diminish significantly. And usually I like to walk around and point at things, but I'm being asked to stand right here right now, so I hope you'll bear with me. So what's going on in the brain over this time period as time's ticking by? Well, in many patients, they present to us initially with a significant penumbra, or area of tissue that's still savable. Oftentimes they have a smaller ischemic core of tissue that's already been permanently damaged. Sometimes they don't, but usually there's a small amount of tissue. But as the minutes tick by, the ischemic core will enlarge and there'll be less savable tissue. And at some point those two areas will be matched, and there's not much we can do, at least to save that tissue that's at risk. So the changes that have happened in the last 10 years have been transformative changes. We have completely new technology we use for imaging stroke acutely, for treating stroke acutely. Again, we're using collaborative practice, not just in the hospital, but outside of the hospital. We've revolutionized our systems of care within the hospital because we have to be very efficient with a lot of people working together. But also, we've developed pre-hospital triage systems to try to get these patients to us in an efficient manner so we can provide them the care we need to. We don't have to really read through this whole list, but the point of this is that the stroke team really touches almost every department in the hospital, from physicians to nurses to technologists. And really all of these people meet on a regular basis. All these people are represented. Here's just the stroke process improvement team members from, there may be some that are a little out of date on this slide, but for just Hoag Hospital, Newport Beach, we meet on a regular basis. We review protocols. We adopt new techniques based on recommendations from anyone in the team. We continually try to make things better and better, because every minute that's saved for that stroke patient could result in a better outcome. There's also an equivalent team at Hoag Hospital, Irvine. A lot of this got rolling after something called the Brain Attack Coalition defined primary and comprehensive level stroke centers. So primary stroke centers were basically centers that were envisioned could give IV TPA and provide basic stroke workup and care. Comprehensive level stroke centers could also provide intra-arterial therapies, and also included specialists such as stroke specialists, neurosurgeons, neuro-ICU kind of level care. And the basic model originally envisioned was you'd have a lot of primary stroke centers, and you'd have a centralized comprehensive level stroke center. That was called the hub and spoke model. And for most major cities, that's how things are developed. In Orange County, some of us felt that that wasn't the ideal model. So when we started working with the Orange County EMS officials through the Orange County Stroke Society, these are the recommendations we recommend that any stroke center would have. So they'd have an IV TPA protocol, but also an intra-arterial thrombolysis protocol. We'd have a database of treatment of patients presenting originally less than 6 hours. That's been stretched out to 8 hours with some newer technologies that have been developed. Having stroke pathways not just for ischemic strokes, but also for intracerebral hemorrhage and subarachnoid, being available for Orange County EMS inspections. Having on call 24/7 a stroke specialist, usually a neurologist, neurosurgeon, and neurointerventionalist. Stroke education with a log of activities, being available for regional transfers, and having a database of patient outcomes to see how everybody's doing. This was successfully enacted in April of 2009, and that made us the first county in the country to be organized around comprehensive level stroke centers. So we really went from the bottom of the barrel to the top as far as the way the county was organized. So I'd like to, in this process, give you an idea of how we're treating these patients now. Just take a patient-based approach. So this is one of our patients, Chad. He was a 44-year-old businessman traveling from Dallas. He collapsed in the elevator. He was last seen normal at 3:45, which is the most important piece of information we're always looking for. That will guide us in what therapies we can give, because still at this point, even though we can get a lot of physiologic data very quickly, we make treatment decisions based on time. He was noted by his coworkers to have a severe left face, arm, and leg weakness, and EMS was called immediately. Now, we work very closely with EMS for triage. They're trained to recognize stroke symptoms. They're trained to transport the patients to an EMS stroke receiving center as soon as possible. They call ahead. They give the patients IV fluids. They don't give dextrose. It used to be that every patient found down got dextrose, but that's not good for stroke patients, so they're more selective in who they give that to these days. This patient was also involved in something called a FastMag study, which was a fast magnesium study, which was the first study that I'm aware of to give acute stroke patients in the field an agent, and they were given magnesium. So he was involved in this study. That study was recently reported at the International Stroke meeting, and it was not a positive study in terms of improving outcomes, but it did serve as the basis for a lot of future studies to come. They proved the proof of concept that you can safely and ethically provide therapies in the field. And there's all sorts of things going on, from CT scanners and ambulances and all sorts of things that are mainly technological limitations. So I think for the future, we're going to see not just it being pushed into hyper acuity in the emergency department, but actually into the field. So I think that's something to come. This is not exactly what they're taught, but this is a very similar tool to what the EMS are taught. It's called the Cincinnati Pre-Hospital Stroke Screen. And it's a pretty simple tool. So you have the patients show or smile, and show their teeth or smile, and you can see on the far side there, the patient's unable to lift the right side of their face. Arm drift, have the person to close their eyes and extend both arms. On the right, the patient's arm is either drifting downwards or they can't lift the arm. Abnormal speech, have the patient repeat a sentence. You can't teach an old dog new tricks. Normal patient uses the correct words with no slurring. Abnormal, the patient slurs words, uses the wrong words, or is unable to speak. Seems almost simplistic, but if any one of these three signs is abnormal, the probability of a stroke within this context is 72%. So they're taught that time is brain. Every minute that ticks by, millions of brain cells can be dying. They're brought emergently to an EMS stroke receiving center. So now we're back in the emergency department. They've received the call and are preparing to receive this patient. They call a code 20, which is what our acute stroke codes are called, which results in ED physician, multiple nurses, and ED staff converging for rapid treatment. I like to call that our stroke swarm. It's similar to a trauma model. Now the ambulance is arriving. The ED physician evaluates the patient. The acute stroke protocol is activated, which results in the appropriate labs being sent immediately to determine the safety of possible treatments and also to rule out other mimics of acute stroke. We treat the patients with an IV fluid bolus. We lay them flat to encourage cerebral perfusion. Acute stroke team is notified, and the acute stroke CT scan protocol is ordered. And this is a busy slide. You're not meant to see all the details, but the point I'm trying to make is we have a very organized system, whereas when you come in with acute stroke symptoms, you're treated through a rapid triage fashion. If you come in with time lasting normal less than 8 hours, it's considered a code 20. Over 8 hours, it's still an emergency, but it's considered a code emergent. The difference being those patients that come after 8 hours are unlikely to benefit from IV or intra-arterial therapies. They receive an MRI protocol in most cases. Those coming acutely actually receive a CT protocol. If hemorrhage is found on those patients, they're shunted to the ICH pathway or the subarachnoid hemorrhage pathway, depending on what we find. Now, these are actually our old paper order sets. This is all electronic order sets at this point. I like to show this just because it's much easier to visualize what actually is going on, but our protocol has recommendations for treatments based on different time points. initial assessments. We collect data on these patients so we can continue to evaluate it to become more efficient, or if there was a problem, we can hopefully identify where there may be a problem, where we can make things better. Initial laboratories are sent, which scans are to be ordered, which team members are to be called. There's a fever protocol and blood pressure protocols depending on what kind of stroke we're dealing with. So now the acute stroke team arrives in the emergency department, the patient's examined. We make a clinical diagnosis of stroke type, location of the stroke within the brain and the blood vessel involved, and the potential cause. In this case, Chad had a left severe hemiparesis, a left heavy sensory deficit, a left neglect, and a left upper motor neuron facial weakness. We make initial suggestions for medical management. The patient's taken a CT quickly. Following the CT, the radiologist and the stroke specialist confer on the CT scans to correlate the pictures that we have with the condition of the patient. Again, this is this collaborative practice, and we're sharing information. And our acute stroke treatment protocol aids in rapidly identifying the best treatment for this acute stroke. And this, in a nutshell, is the protocol that we're considering, what we're considering doing. We consider IV TPA for 0 to 4.5 hours. The window from 3 to 4.5 hours has some additional limitations that I'll go over with you. 0 to 8 hours, we're thinking about intra-arterial therapy, which can mean intra-arterial TPA delivered right at the site interventionally. We have other catheters. There's a penumbra catheter that I'll show you a little later. There's a suction catheter that can suck the clot out of the brain. Some of the newer devices are retrievable stents. There's a solitaire device and a Trevo device. I'm going to show you an example that, again, that's a mechanical device to pull a clot out of the brain. Another one's a Merci concentric clot removal device that we've been part of the study looking at that particular device. We can also do intraarterial in some cases for failure of IV TPAs. If somebody comes within an IV TPA window, if they're a candidate for that, we try to give them IV TPA, but we monitor the patients, and if that is a failure and they're still a good candidate for intraarterial, we can then progress to intraarterial with appropriate counseling with the patient and the family members. In the case of basilar occlusions, we have an extended window, really, because those patients are potentially so devastatingly affected. There's some reason to think that they may have a longer window. If for a complete basilar occlusion, the risk of death and worse, being locked in, is very high. So we're a little more aggressive in those cases, potentially, if it's appropriate. Just a word on this extended window from 3 to 4.5 hours. This is the American Heart Association, Stroke Association guidelines. So for patients greater than 80 years or with oral anticoagulants or a prior history of stroke and diabetes, they're excluded from the extended window of IV TPA. Sometimes they'll be candidates for intraarterial even if they're not a candidate for the extended window of IV TPA. The reason for this, as I showed you before, the margin of benefit is relatively small in that extended window. So we pay more attention to the other risk factors because those things that increase the risk are going to make the potential margin of benefit very narrow. So Chad's going to a CT because it presented within 6 hours. This is our acute protocol. So we do a CT of the brain to evaluate for bleeding, which is pretty much standard of care. That's all that was done in the original NINDS trial. We also do a CT angiogram to identify the occluded blood vessel or potentially an aneurysm. And we do a CT perfusion study to identify the area of brain not receiving adequate blood supply and also to identify an area of permanently damaged tissue. We use something called cerebral blood volume for that. I can show you what that looks like. And I like to use this slide. This is a virtual dissection using just CT technology. So when we choose to use CT, this is a very high resolution, very fast CT technology. And you can see the blood vessels, the vertebral arteries flowing up into the basilar artery. We can get a lot of information very quickly to make a decision in these critical patients without any time lost. And we choose this for these patients. This is a very advanced technology. This isn't just a old-fashioned basic CAT scan. So here's Chad's scan. And let's see, I guess I'll have the, that's not, Well, I'll just have to describe it. So, so what we're seeing here is basically the CAT scan is pretty much normal. For those very astute, they might notice there's a little density of the right MCA, that hyperdensity in a linear distribution near the temporal lobe. And that's pretty much what a regular CAT scan is going to show you. A CAT scan is most helpful for showing you acute blood. Down below, we see the CT angiogram. To the far side of the screen, we can see the middle cerebral arteries filling nicely. On this side of the screen, it stops abruptly. That's because there's a blood clot in the M1, or the first branch of the middle cerebral artery. On the perfusion scanning, which is on the far side, what we can see is a decreased flow to that whole MCA distribution. And there may be a small area that's permanently damaged based on the cerebral blood volume. And here's a 3D rendition of that. It's a little easier to see. It's nice because we can see how that is actually positioned within the head. So once we receive this information, we call a code TPA, which is kind of a second surge of activity, which results in nurses coming back, mixing up the TPA, placing a Foley, doing several things that we need to get done in a very timely fashion. IV TPA for this patient started at 5:05. However, we do call the neurointerventional radiology team. The reason we do that, this is a young patient. He doesn't have a lot of comorbidities, excellent candidate for intra-arterial therapy. Also, when there's a large occlusion, we know there's a high likelihood that he might benefit from intra-arterial therapy. So if you can imagine that TPA in a long clot is kind of eating away at the very end. If that's a very short clot, perhaps that will work. In other cases, it does not. And even those that it does open, about 30% of cases based on transcranial Doppler data we have, it will reocclude. So this idea of a clot either being there or not being there is a little simplified. It's actually continually in flux between clotting and bleeding, and we're just trying to do everything we can to tip the scales to open up that clot. Indeed, he does not significantly improve. He is brought to angio and gets a formal cerebral angiogram, which does confirm that his MCA is still occluded. And he gets treated with something called the solitaire device. And again, this is a retrievable stent device meant to snare the clot and bring it out. And here is actual images. In the closest panel, we can see the carotid artery filling nicely. However, the MC is not filling. These other studies, you can see the tiny catheter going up inside the skull. The after picture down here below, we can see the internal carotid artery filling and all the MCA branches filling nicely. Following up with a CAT scan, it's hard to see if there's any damage on that CAT scan at all the next day. And that's the blood clot that they pulled out. And just to give you a more pictorial representation, so this is a little cartoon video of what happens. This is down in the internal carotid artery. A wire has been thread up. The catheter is fed over the wire all the way up to the middle cerebral artery. The wire is passed through the clot. Catheters followed over the wire. This is the stent device being inserted through the catheter across the clot. Catheter is removed. The stent intercalates into the clot. in the carotid, a balloon's blown up to occlude distal blood flow to prevent distal embolization. Clot's retracted. They didn't show blood flow is restored by deflating the balloon, and then you end up with that blood clot like we saw on that patient. So in this patient, by the next morning, the patient was back to normal. At that time, we could find some very subtle left-sided weakness, decreased sensation that the patient wasn't even aware of. These are very subtle signs. 2 days later, we couldn't even find any significant deficit. He was discharged to fly back to Dallas. 30 and 90 days later, he was called. We call all of our stroke patients, so it's kind of unique. We collect data on all of our stroke patients, whether they're within our system or not. He was back to all prior activities and doing great. Here's another example. This is a 58-year-old man who, while driving to work with colleagues at 9:30 a.m., kind of near the El Toro Y, right near Hoag Hospital, Irvine, he had a sudden onset of severe right-sided weakness, loss of sensation, and inability to speak or understand what's being said to him. He was brought by his colleagues. They drove him right to Hoag Hospital, Irvine, because they were right there. Obviously, the same code was called that I described before. These were the findings. The CAT scan, again, is basically normal. If you can look on the far side of the screen, which is the left side of the brain, there's a tiny hyperdensity, a dense MCA sign. On the CT angiogram in the center of the picture, you can see, again, the right MCA this time is filling robustly, but the left MCA has an acute occlusion. Similarly, in the perfusion studies, we can see that perfusion deficit is basically affecting the entire left side of the brain. The ECU physician communicated with the stroke specialist. We can remotely review the films, and we reviewed the patient with the robot. IV TPA was initiated at 9:30, and the patient was transported by ambulance to Hoag Hospital, Newport Beach, for an angiogram again. We thought he may be a candidate for intra-arterial therapy as well. So this was actually phase 1 of the robot. This is the robot we used in this case. This was actually on the front page of the register the day that Hoag Hospital Irvine opened. I don't know if you can, that's my face on, and I'm green. For some reason, we're having technical difficulties on that one day. But the reason I like to show this is because when we start talking about examining patients with robots, it all sounds very cold and clinical. Really, it's just a communication device. It's a way for me to drive around. I can drive this remotely, to go to the patient's bedside. I can look at the monitor. I can blow it up and look at the rhythm strip. I can look at the blood pressure. You know, this is Kanoe and I interacting. It's like a normal human interaction. It's just, I don't have to get in my car, wait through traffic on the 405, eventually get over there. I'm there instantly. So this is what the newer robot looks like. It's a little slicker. And actually, this one can drive itself. So if I tell it to go to ER bed 5, it will go from its station and just automatically drive there. Once it's there, I drive in, interact with the family, interact with the patient, and I can do an exam with the assistance of the nurse. So he actually improved after the IV TPA. So this is a technique we call drip and ship. So we're dripping in the IV TPA. In the meantime, an ambulance is bringing the patient to Newport Beach, which is where we do all of our interventional neurologic procedures. And he was not completely improved. So he did go to angio, and some residual clot was removed with another stent retrieval device. And this is an MRI follow-up, and even on the MRI we can see some subtle hyper-intense abnormalities where the brain was damaged. But compared to the entire side of the brain potentially being infarcted, that's the amount of damage he received. Despite that, by the next morning he was speaking with only mild deficit, had a mild right-sided weakness and no numbness. With our 90-day follow-up call, he reported he was almost normal, but he was back to all prior activities. So here's another patient. This is a patient, Alan. He's a 90-year-old male. So you can see we find a lot of young strokes. So this idea that stroke doesn't happen to young people is completely incorrect. I think when you realize that it can happen to young people, you find a lot of young people having strokes. So we treat a lot of young people here, and we treat a lot of people on the other end of the spectrum. So this is a 90-year-old male, very independent. He still golfing, volunteering at Veterans Center. He has a past medical history of high blood pressure, high cholesterol, and he developed sudden onset of weakness in a fall. It was not significantly traumatic. Again, code 20 protocol is activated. From the CT, we don't really see any abnormality. On the CT perfusion studies, it's quite obvious he's got a large area of hypoperfusion on the left side of the brain. Probably also, if you look at the FAR study where it's darkest, probably there are some areas that are permanently damaged due to low blood flow. Again, he has a left MCA occlusion seen on the CT angiogram. He's taken emergently to cerebral angiogram because he was outside of the IV TPA window. At cerebral angiogram, it again shows a left MCA occlusion. And he was treated with something called the penumbra device. So they've already threaded the wire up to the blood clot, just like in the last example. The suction catheter had been threaded over that. There's an interluminal device called a separator, which can be used to macerate the clot and also to keep the lumen of the suction catheter open. There's an external suction canister that's been activated. For soft clot, this works very well. A lot of times it looks very easy with these cartoons. This is actually obviously a false blood vessel, but a true blood clot, and it can show you for a soft clot how quickly it can actually work sucking up the clots. So I think the most important thing is having a system in place where we can treat people effectively, and we're getting new tools all the time, different tools for different situations, for either IV therapies or for interventional therapies. Okay, and here's the post-procedure. We can see, again, where the MCA had been completely blocked off, it's now flowing robustly, so complete flow was restored in this case. This is the afterwards. The MRI shows just a subtle diffusion abnormality consistent with some ischemia there. The follow-up CT really doesn't show anything except for an old stroke on the opposite side. Next morning, the patient had mild right-sided weakness, mild word-finding difficulties, but had an excellent prognosis. Again, at 90 days, he was back to all of his prior activities and reported that he had to work on his golf swing. So over this period of time, we've been able to dramatically impact patients in terms of the percentage of patients that are being treated. So we're still hovering around about 15% combined intra-arterial and IV therapies. And this is for all comers, including patients who come in 2 weeks after their stroke, and we treat them in our program. However, for those patients that come in that are brought in by the EMS triage system, we're treating 67%. So if people activate the TPA system, for all those that are coming in, we're still treating 67%. So if you compare that to 3% 10 years ago or less, we've made a dramatic improvement. Even more importantly, if you come in with a stroke, and this includes people who came in late, didn't get appropriate therapies at all, 60% of people will get back to a modified Rankin scale of 0 to 1, meaning back to all their prior activities with either no deficit or only minimal deficit. So you're 60% likely to get back to your activities if you come here for a stroke. We did publish our initial data in the journal Stroke in collaboration with the other centers in Orange County. And I just want to emphasize, like, maybe I'm a glass half full kind of guy, but so we're treating 15% of people. The number one reason people don't get treated is they don't activate EMS and they don't get here quickly enough. So we still have 85% of patients not getting the kinds of therapies, or at least not being acutely evaluated for the types of therapies that I'd like them to be treated with. So education is very important to us at this point. We do community educations. We educate by a whole variety of ways. We like to teach FAST, which is face, arm, speech, time. It's really similar to the Cincinnati pre-hospital stroke screen for lay people. Face, does the face look uneven? Ask them to smile. Arm, does one arm drift down? Ask them to raise both arms. Speech, does their speech sound strange? Ask them to repeat a phrase. And time, call 911. And that's what I have to say. We are going to have a really big, as you know, this, May was Stroke Month. We've done a lot of education. We're actually on July 5th. We've organized a program called Strike Out for Stroke at Angel Stadium. So at Angel Stadium, they're going to be doing, EMS is going to be there on site. We're going to be doing blood pressure screenings, stroke risk assessments, as well as handing out T-shirts. We're going to speak. We're going to have a stroke survivor throughout the first pitch. So that's a big thing. If anyone would like to come out for that, we'd love to have you. Thanks for listening.